Good evening, all. For today's e-Gurukul session of case discussion, and for today's case discussion, for this journey, Baldev sir has already joined us. Sir is going to take us through the flights of different modes and how to go for the case history and to reach to the diagnosis. And for today, we have my dear friend Dr. Anusha as expert also. For today's episode, I'm inviting our President, Dr. Jhankhana Sanghavi Madam, for her welcome address.
Thank you, Dr. Nehal. Good evening, everyone. I welcome respected Dr. Baldev Prajapati sir, Dr. Nehal, Dr. Lata, and today's mentor and a journal coordinator, Dr. Rekha Madam, expert Dr. Anusha Raj, and today's presenter, Dr. Richa Gupta. Case presentation is always a brainstorming exercise. And I am sure that today's exercise, our Dr. Richa Gupta, she proved herself as a Dhurandhar. We are sure because she proved herself as a Dhurandhar. So let's start with brainstorming exercise with respected sir, Dr. Baldev Prajapati sir. Not taking much of your time. Over to Dr. Nehal, please.
Thank you, madam. And I welcome Dr. Sandeep Trivedi, sir, Vice President West Zone, also here.
Yes.
Sir is always there motivating us every time. Welcome, Rekha. And now I'm handing over to Lata, our Chief Project Coordinator, for introduction of the faculties and specially expert.
Good evening, everyone. Thank you, Nehal ma'am, for your kind words. Today we are going to have another mind-blowing session, a case presentation by Dr. Richa Gupta, who is third-year resident at Gujarat Adani Institute of Medical Science. Her mentor is Dr. Rekha Thaddanee ma'am, who is professor and head of department at Gujarat Adani Institute of Medical Science at Bhuj, Kutch, Gujarat. We have expert as Dr. Anusha Raj K ma'am, who is pediatric neurologist at Mysuru. She's an expert in her work and she's superb, having so many things that in a short span of time we cannot elaborate what are the skills she's having. So welcome ma'am and welcome everyone here. Nehal ma'am, please.
Over to you, sir. Platform is all yours.
Good evening, friends.
Good evening, sir.
Good evening.
Welcome. Sir. Good evening, everybody.
Good evening, sir.
Good evening. Very nice of you.
Good evening.
Presence of everybody.
Good evening, Sandeep Trivedi sir. Good evening.
Good evening, Sandeep sir.
Good evening, ma'am. Good evening, Anusha.
Good evening, sir.
Yes, good evening, everybody. Welcome to this our PG clinic. As always we do, the presenter will start with the history. We will analyze. In between, we'll request her to stop the sharing. And in that way, we'll see that what is the development of the case. Meanwhile, I request Dr. Richa that can you identify some of your other colleagues so that we can involve them in our discussion and discussion can be live. Richa, are other friends from your institution?
Yes, sir. Raju has joined, sir.
Dr. Raju.
And
Dr. Raju Garchar is there, yes. Anybody else? Or I think others, those who are on the screen with the students, you can identify. I think Dr. Komal, I know. Probably, Dr. Komal, are you there? From which institution, Dr. Komal? Okay, I think meanwhile they will start. Anybody else, Dr. Richa, besides Dr. Raju?
Sir, others are joining, sir, in few minutes.
Okay. Let us see. No problem. Because why I'm requesting that if the students are participating, we can have the good discussion rather than only to discuss with presenter Dr. Richa. Anyway, let us start with the history part. I request Dr. Richa to share the PPT and start.
Dr. Jayank has also, sir, also joined the meeting.
Dr. Jay.
Yes, sir.
Okay, Dr. Jay. Fine. Dr. Rajeshwari.
No, sir.
Dr. Rajeshwari, can you identify yourself, please, so that we know that from which institution you are there? Please, I think students should not hesitate. And second thing, this is not, I will say, just case discussion. It's a training given that how best we can present, how best we can identify ourselves. And therefore, I think whenever you start, even because you know that everybody may not be knowing that from which institution you are representing. So you can just say, as suppose Dr. Richa, that I am Dr. Richa Gupta, I am from Bhuj Medical College, so that people come to know. And then even you can participate in the discussion. You can put your comments, even some questions. Even you can ask the question to the presenter. Suppose if you don't have the clarity, but I'm sure that that's the way that how everybody can learn. Anyway, with these few words and remark, I request Dr. Richa to start her presentation.
Okay, sir. Good evening, everyone present here. Today, I, Dr. Richa, third year resident in Gujarat Adani Institute of Medical Science, is going to present a case on the
Dr. Richa, can you just make it full screen?
Yes, sir.
Slideshow?
Yes.
Yeah, fine, good. Please go ahead.
My mentor is Dr. Rekha ma'am. She's the professor and the head of department. Sir, shall I start?
Yes, sir, please.
Okay. Informant being mother presented with an 8-year-old male child born out of consanguineous marriage, Muslim by religion, and belonging to lower social economical class, according to modified Kuppaswamy classification, residing at Mankua, Bhuj came to Gujarat Adani Institute of Medical Science Emergency Department with the chief complaint of weakness in lower limb since 12 hours, not able to sit since 10 hours, unable to walk since 6 hours, and weakness in holding objects in hand since 2 hours. History of presenting illness. The child was normal before 12 hours. Child noticed that he started developing weakness in both lower limbs, and the child had difficulty in waking up from bed and woke up by taking support of hand since 10 hours. The child was not able to stand on his leg and was not able to hold grip of slippers since 6 hours. Later, mother also complained that the weakness started to involve both upper limbs, and child was not able to feed himself since 2 hours. There was no history of fever at the onset of illness.
Anyway, can you stop sharing? Meanwhile,
okay, sir.
We'll go for the negative points later on.
Okay, sir.
I think always let us take in this way that you are sitting in your OPD and the child enters your room. And mother starts the complaint in this fashion, what Dr. Richa described. Who will take the initiation? That how will you think? She said that here is the 8-year-old male. First, I will say very acutely, there was the weakness of both lower limbs, and even spreading also, progressing also, very rapidly with the involvement of even the trunk because not able to sit, and even not good grip, that means even the upper limbs also. So having this story, number one, I think first, what other questions you should ask in deriving the history so that you can have some idea that what is a likely problem with the child. Who will initiate? That first, I think it is very important that these were the complaints from the mother. But as a clinician, what other questions you would like to ask so that probably you can have the clarity or you have some thoughts? Forget regarding the case. And second thing, always remember in the exam, nobody is interested in your case or diagnosis. No examiner is interested. Examiner is interested in how much you know the pediatrics. That case discussion is, I will say, one forum that having this type of the case, they can take the further discussion. They are not interested in the particular case or even the diagnosis. And never understand that you have given the diagnosis and you are going to get the good scoring or even the passing. How your conversation, how your interactions take place, how you are able to prove the clinician, the examiners, that yes, I am the MD candidate and I stand even having this particular level of the knowledge, and then they will decide whether it can be passed or not. So I think this clarity should be there in our mind to all the students, that whenever you are talking, you are presenting the case, keep in mind, because your focus is on one particular, I would say, case, which is on the contrary misleading. So my question, having these complaints from the mother, what other questions you will ask the mother? Or even suppose if you don't have the clarity, or you can ask Dr. Richa, whether did she ask the mother, whether she gathered all the informations. I think that will be the way. Who will take the, I will say, initiation? Dr. Raju, can you start it? Then others will join you. Yes, Dr. Raju? Very good. At least he has made his video on. This is also the, I will say, gradually I am considering this is the bold step to keep your video on, right? Giving your identity. Yes, Dr. Raju, please.
Yes, sir.
What other questions you will ask to the mother? Suppose if you were sitting in the OPD and this patient presented to you.
Sir, first ask about nutrition.
Okay. What questions will ask for the nutrition?
Baby, what feed she give to baby?
She's an 8 years old boy.
So what diet she give to baby?
And suppose let me say, suppose mother will provide the information. How does it help you in your thought process? Suppose mother says 8 years old boy taking the whole family diet in the morning, the milk and some snacks or even the breakfast. Later on, even the lunch also takes all the rice, dal, everything. I think Gujarati family. So they are taking the full dish. Even afternoon also take the milk, and in the evening also khichdi, bhakri, something like that. So I will say this will be the common information. How that information helps you for thought process. There is another thing, that by just putting the question or information is not sufficient. Whatever we speak, whatever information we ask, that is having some of our thoughts, that presence or absence of information will help me for further thought process. Right. So having that, Dr. Raju, what is your idea of asking the diet or nutrition?
Sir, how much amount of diet she given to baby, and what is the calorie count of that?
Dr. Raju, my question. Okay, she will inform. I think that is another thing in the exam. Please follow the address question. You should respond to the question in the exam. And therefore, I remember Dr. Ambedkar sir always he say that your response should be ABC. What is ABC? It should be accurate. B, that means it should be brief. And C, very correct, concise. Right. So I think my question is, whatever the nutrition, dietary history mother will provide you, how it makes, I will say, how it helps you for thought process. That suppose something deficit or something excess or something like that, which will create this problem. Anyway, let me even, don't hesitate, let me answer. Probably any dietary deficiency or something, we are not expecting that going to present in this way. The acute weakness. Even, yes, some nutritional problems can present with the problem, but not in this way. But yes, always remember one or two things. Any this type of this is not even the acute, I will call it the hyperacute. There is a difference in the acute and hyperacute. Acute usually takes few days. Usually we say 7 days to 10 days time, illness, we say acute. Subacute usually few weeks. May take the 2 weeks, 3 weeks, like that. While in a case of chronic, that means it takes even few weeks to months together. This is arbitrary understanding. But within few hours, if whatever the illness is there, it's a hyperacute. On the other, let me address this question. Suppose if you say hyperacute illness, can you enumerate some of them which presents with the hyperacute? That means what we mean by the hyperacute? Previous moment or even hour, child is absolutely fine. And suddenly within few minutes or hours, presents to you with some serious condition. So enumerate some condition. Richa, yes, very good.
Yes, sir. There can be seizures, sir, or abnormal movements can present within few.
No, my question is very clear. I'm sure that you should follow my question. Which type of the conditions? It's a group of disease. I do not want the very specific disease even. Suppose if you are able to answer, it's okay. But here that means what type of the insult, injury, problem to the, I will say, body, what type of the disease process, which presents with suddenly within few hours. Well, let me give the idea so that you can think. Suppose road accident.
TIA.
Road accident is the example. That previous moment the person is fine. Right? Like that trauma.
Thromboembolical conditions.
Very good. That thromboembolic, particularly the embolism, suddenly. Right? Stroke. Yeah, stroke also presents in this.
Transient ischemic attacks.
Yes, Dr. Chandrak, very good. You want transient some.
Yes, sir.
That is, in short, if you want to answer vascular problem. Yes, Dr. Raju, I think your voice is breaking. There is some problem.
Guillain-Barré syndrome. Sir, Guillain-Barré syndrome.
Okay, Guillain-Barré syndrome, not so common that presentation, but actually it can present. Anyway, please, I want to give the general idea as a clinician. As I said, my interest is not to discuss the particular case. My interest to guide you for your thought process. That suddenly this was the presentation, think first always the trauma, number one, and in the children it's possible. Even sometimes parents have not noted. That is another thing. Suppose the parents have noted, they will give the history. But sometimes parents have not observed. They were not present, mother was not there. Suddenly found the child with some problem. And in that type of story, I would like to go for asking for the trauma. Number one. Second, any toxin. Toxin presents suddenly. Some toxins may take some time, but certain toxins suddenly. Child has taken, suppose, some chemical substance, organophosphorus, or the kerosene child was playing, right? Or child has taken some, I will say, medicines of the grandparents. This thing can happen. So that type of a thing, yes, very good. Somebody has put it some insect bite or snake bite. Snake bite can present in this way. Even I will say, rural area, child is playing and the child may take some dhatura, even these seeds, and may develop the dhatura poisoning. So what I mean to say, some toxins, keep in mind, they can present suddenly. Vascular problems can present suddenly. Trauma can, and second, always immune reaction, even anaphylaxis. Anaphylaxis presents suddenly. Maybe even due to insect bite, not necessarily always due to some drug or medicine. Or any immune disorder. That immune disorders can be due to the involvement of various. So, this is the thing which I wanted to give the idea. That if this type of story is there within few hours, child is presented, and here, progress is also very fast. That means you can understand that either some toxin or, now you can think that which type of the conditions can present, etiological. Always try to think in this way. What is the anatomy? Even first here you should decide that which system is involved. What apparently you are talking of the nervous system may not be the nervous system. Weakness can be of two types. There will be sometimes loss of energy. Loss of energy can present with the weakness. Suppose some electrolyte disturbances, hypokalemia, or even hypoglycemia. or another is the neurological. And neurological weakness is different thing. So you want to try to define this exactly, that what type of the problem, is it really some energy problem, lack of energy, or really some neurological, right? And therefore you can think in this way. Now lack of energy, even that can also present in this way. Suppose this type of the weakness, if you think that the lower limb developed the weakness, then the trunk and probably upper limb in this way. But usually, suppose simultaneously it develops hypothalamic periodic paralysis. It can present in this way, right? Or even suddenly due to some electrolyte disturbances, right? Or even maybe the neurological. Now you can think in both the directions. What was my idea to give this, to boost up your thought process? That always think that acute, subacute, chronic, which type of the disorders can present with specific groups, and then which common type of the disorder. And always try to think anatomy, then that is the pathology, that is the disease process, and possible you can think the common conditions. I think with that one. Now coming back to our case, I think that was good that several students started to respond. Yes, Dr. Chandra, can you take it? What is your thought process having this idea with our patient, 8 years old male? Dr. Richa said that the weakness parents noted first in lower limbs and within few hours when trunk and the upper limbs like that.
Yes, sir. Bilateral symmetrical ascending paralysis, sir.
Okay. How did you decide it is bilateral symmetrical?
Sir, both lower limb are affected initially and then progress to trunk and then upper limb, sir.
Okay. So at least it's a good idea that you can think that something is there which initially caused. But suppose if it is this type of the story, then what type of the neurological problem? Is it central or peripheral?
Sir, peripheral.
Why not central?
Sir, centrally
there is
Yes, Richa, one by one. I hope you must have come with the
history
preparation.
of altered sensation.
Okay, very good. That's some of the manifestations of the central origin. Altered sensorium, what else? Yes, now we can take it. May not be in our patient, as how we want to know.
The patient may have some kind of central nervous system involvement.
Right.
Or in that
somebody has put, I will say, but Zoom user and everything, please name yourself. Always, as I said, always give your identity. That is the first step which all of us should learn. Even don't hesitate, my answer may be wrong, no problem. But even suppose tomorrow you are in some conference, national or international conference, nobody knows you. Suppose if I go to the south, people may not be knowing me. So first I should always say that I am Dr. Baldev Prajapati, I am from Ahmedabad and I am pediatrician. And I am suppose holding some post, you can say. Always I think that is the first lesson, even as a student, learn it. That's good. Anyway, Richa, what else? Suppose if it is any problem with the central origin, what other features will indicate that this is likely the central origin? One, as you said, central sensorium, yes, agree. What else? Somebody had put the seizures, very good point. Seizures probably favoring the central origin, very good. Then?
Sir, it can be involving, the reflexes might be
reflexes and everything will be on examination. That part we don't know, right? But suppose the altered sensorium, seizures,
inspection, hypertonia.
Even there may
hypertonia.
Hypertonia. Another thing, hypertonia can be even with these peripheral nervous system also. Commonly, yes, but there are certain conditions. Even suppose there is even the paraplegia. Not necessarily always it will be, I will say paraplegia will be having this hypotonia. Can present even with this hypotonia also. So very characteristic, specific points. Suppose impairment of some memory, problem of speech. So all the higher functions.
Gesticulations.
Very good.
Sir, behavior problems.
Okay, fine. I think now you are gradually sensitized, started to respond. Good. But then here it's the Chandra, now coming back to you.
Yes,
It is
sir.
central or periphery?
Yes, sir.
It is central origin or periphery in our case?
Sir, mostly peripheral involvement, sir.
Okay, peripheral involvement. Good. So come to the conclusion. Now, peripheral, suppose if you are thinking, what are the problems can present? With this type of the...
Sir, in peripheral, problems are such as fasciculations, then muscle atrophy. Mostly group of muscles
I will give the idea. I will
not
give the
in.
idea.
Yes.
I will give the idea.
Yes, sir.
Always think methodologically. In the
Yes, sir.
medicine, if you have that idea, that helps a lot. Even
Yes, sir.
in even uncommon condition you can reach. So suppose if you are thinking for the peripheral nervous system problem, try to answer, is it anterior horn cell problem?
Yes, sir.
Is it a peripheral nerve problem? It's a neuromuscular junction problem, or it's a muscle
Yes, sir.
problem. And you know, every disorder is having the specific characteristics that you can check. Is it there or not? What does it
Yes, sir.
indicate? And every time that demarcation may not be right. But most of the times, if you go for the methodological thought process, you'll be right. So here, I think, and for that reason, I say, my first question was that if you have these points in your mind, you will ask the questions to the mother to gather the information. That is there any other point indicating specific?
Yes,
Even suppose presence of fever, that will give the idea of pathology also. It is infective, non-infective, something like that. Whether recently any vaccine is taken, whether the child was in some rural area, then snake bite can also be there. Right? Whether taken some medicine or something, some drug. So what was my first question? With this type of presentation, I will go series of questions. Keeping in mind, you know, always we'll ask the questions for two, you know, our questions should be also be thoughtful. Not anything comes to our mind. One group of my questions should be to know exactly that what type of the disorder it is, that is to decide the anatomy. My second group of the questions, I want to know what type of the pathology or the possible etiology. Keeping in mind various conditions in my mind, I will ask several questions, put on the paper, so that it will give me some clarity that what does it indicate. May not be clear answer, but yes, it will give some clarity. So that was the idea in any case. And one thing is very important, which I want to draw attention. It is said that if you have taken the good history, very good history, 80% diagnosis should be revealed only from the history. More than 80%. MRI will not give the answer. MRI sometimes mislead you. But if I have gone for the good history, and suppose according to my history and thought process, if I don't get even the MRI or something, rather than going challenge to that, I will challenge my history. Go back to the history. That's something I have missed probably. That's the, I will say, beauty of the medicine, and that we should learn. Now coming back to Chandrak, because he said that bilateral, symmetrical very nicely. Okay.
Yes, sir.
Suppose if I believe you, then what will be your thought process? What type of the disorder it is?
Sorry, sir.
What type of the disease it is?
It is, sir, element type of
lower motor neuron type of disease. Yes,
disease.
good. And if you are saying, because you said it is bilateral, it is symmetrical, it is ascending even, you say. You know,
Yes, sir.
Another thing in the medicine, I want your attention.
Yes, sir.
Always in the description, give the multiple adjectives. That adjectives will give the description, will create some picture in the mind of the listener that what you are going to create. If you say acute, subacute, chronic. Second, always decide whether the disease is progressive or static. Suppose progressive, it's a slowly progressive or rapidly progressive. You know,
Yes,
all
sir.
these things will give some very correct specific idea. Here, I think if you say, you can say it's an acute or probably hyperacute disease. Right. Second thing, as you say, it is the ascending in pattern. one more adjective, it is bilateral symmetrical. One more you can say even progressive. Even still you can add one more adjective, it is rapidly progressive. All the things are having some value. That means whatever the disease, but disease is having peripheral nervous system problem, it's an acute disease, it is a progressive disease, it is ascending disease, it is rapidly progressive disease. Just make, I will say, this type of the statement, and that will be the beauty of the medicine. Why I'm coming to this point, not just for that may give some idea in your thought process. And that's why even uncommon condition you can diagnose from this. Anyway, I think before we go for the details, we'll come to the more of the informations and then we'll proceed further. I think before we go the negative points, let us take any, I will say, comment from Dr. Anusha, because naturally she is being neurologist, must be having something more to mention, which probably may be the learning for all of us. Yes, Dr. Anusha, please.
Sir, actually, I think from what Dr. Richa presented to the way you elaborated the presenting history of weakness, like how we should not have a prejudice in mind, like how we should tell whether it's an timeline of the event, whether it is what is the involvement, lower limb to upper limb to lower limb, proximal to distal, progressive, non-progressive, and symmetrical, asymmetrical, and like as a story, as you said, as a story if we tell, then it paints a picture. And as you said, I would totally agree, history gives us the diagnosis. It's not as a clinician we should totally elaborate the history and give importance to history, even though nowadays it's an era of investigations and evidence-based medicine. But I still believe what my teachers taught me, that history gives us everything, and we should totally stress on history as students. When we are learning, we should give utmost importance to history, and I think you've wonderfully elucidated everything. I think as we go more, I would like to add.
Yes. Sorry, Dr. Anusha, I would like to know regarding your teacher.
Yes, sir. So, sir, I think I did my MBBS from Mysore Medical College.
Right. Dr. Narayappa, I think you must be knowing.
Yes. And then my post-graduation, I did from KMC Manipal, Kasturba Medical College.
Yes.
I think if I'm not wrong, Dr. Nalini ma'am, my teacher is if I'm not wrong. Yes, I would like to say hi to madam. So I was Nalini ma'am student. And then I did my pediatric neurology under Dr. Vaikunt Raju sir from Indira Gandhi Institute of Child Health.
Yes. I know all the senior friends. That's why I thought that I may be aware of it.
I should say I'm always blessed to have wonderful teachers.
Anyway, I think let us go further. Dr. Richa, you can take the story further. And please, all the students should be alert and ready, and even try to listen and even create your own thoughts.
Sir, there was no history of fever at the onset of the illness. There was no history of headache, vomiting, or altered sensorium. There was no history of breathing difficulty, sweating, and palpitation. There was no history of bladder and bowel involvement. There was no history of difficulty in chewing and swallowing. No history of difficulty in closing eyes. No history of difficulty in drooping of eyes or double vision. There was no history of diurnal variation in weakness. No history of throat pain and fever. There was no history of recent IM injection or trauma. No history of ingestion of canned food or honey, and no injection of animal bite.
Fine. Can you stop sharing? I think that point we'll elaborate in details. It is very important because negative history. Let us, I will say, take one by one. Even other students should respond that why Dr. Richa has gone for a particular point. She has mentioned no history of fever at onset of illness. Chandra, what is the importance?
Sir, if weakness with the fever suggestive of infective etiology, so we can differentiate.
Please, sorry, one correction always. When the fever is there, not necessarily always infection. It's an inflammation. And that inflammation commonly due to infection, yes, but non-infective conditions as inflammation can also present. Very classically, I will say immune disorders. Immune disorder or something even they can present. So simply you can say that no evidence of inflammation, at least we can consider. Probably infection goes down. Always in the exam,
Yes, sir.
answer very precisely. That will create your value. Right?
Yes, sir.
Here, we are here even not only for the clinical discovery, the practitioner, I know that all the students. So I will keep in mind that how best even you can perform in the exam. And
Yes,
therefore
sir.
answer very precisely. You can say that absence of fever, probably there is no inflammation, specifically less likely the infection. We can say less
Infection.
likely some infections even without fever also can present. But
Yes,
commonly
sir.
I think we can answer and that will be the good. Anyway,
Yes, sir.
fine. Second, she had mentioned headache, vomiting, and altered sensorium. What is her idea?
Central
Sir.
nervous system.
Sorry?
The central nervous system involvement.
Richa, I will come to you the last. Naturally, you must have come to you. Let others even participate. I think Dr. Raju is also there. Yes, Dr. Chandra? Or
Sir.
Dr. Dhanush has said encephalitis. It is only encephalitis will present in this way.
Sir, meningeal involvement and brain matter involvement, sir.
Very simply, always another thing in the medicine, the presence of some symptom complex, some symptoms together will indicate some syndromic growth. May not be that one particular condition I can't say, because several conditions can present with a headache, vomiting, altered sensorium. What does it indicate? Raised intracranial pressure.
Yes, sir.
In raised intracranial pressure, which present with the headache, vomiting, and altered sensorium, very classical on the complaint. Suppose any patient comes to you with headache, vomiting, and altered sensorium, first I will think the raised intracranial pressure. Maybe the case of hydrocephalus.
Yes, sir.
Maybe the space occupying lesion. Suppose with the fever, maybe even some inflammation or infection. That's the thing, that how it will help me for my further thought process. And that I want to sensitize all of you that should be our thought process. I think with that fashion you can answer. No history of breathing difficulties, sweating, and palpitation. Dr. Jay, please don't run away. Yeah. Very nice. Please, what is your idea? She has mentioned no history of breathing difficulty, sweating, and palpitation. What is her idea? What she wants to confirm or explore?
Autonomic nervous system may.
Very good. Sweating and palpitation particularly, right? That means she wants to decide, along with this peripheral nervous system, whether the autonomous nervous system disturbances are there or not. And it's a good point. Certainly good. Similarly, she has mentioned the bladder and bowel involvement.
Spinal cord etiology.
Here, suppose specifically, what is her idea? Before that, let me ask you one question. Which are the two common conditions? Two common conditions I am asking very precisely, which will present in this way. Very good. Somebody has put, yes, Dr. Mega, transverse myelitis. On the contrary, transverse myelitis, commonly the bladder and bowel involvement. Right? Suppose if you are thinking for, suppose, Guillain-Barré or polio, in which condition it will be common with the bladder and bowel involvement? If I ask you the very clear question.
Transverse myelitis.
Yeah, so that's the thing, that how we should give the importance. No history of nicotine, chewing and swallowing, Dr. Jay? How it is relevant, chewing and swallowing? Chandra, any idea? Or then
Yes,
yes,
sir. Bulbar and pseudobulbar palsy involvement to rule out bulbar palsy and pseudobulbar palsy.
How the chewing and swallowing? That means in which type of the disorder the chewing and swallowing will be involved?
Sir, mostly cranial nerve palsy, sir. Muscle of mastication involvement.
Swallowing?
Swallowing, sir, pharyngeal muscles involvement.
And then in which disorder you are thinking that these cranial nerves are likely involved? Is there any idea or link? Let me ask Dr. Richa, what was their idea?
Sir, to rule out any cranial nerve involvement, I took the history.
Why I will say you have taken any cranial nerve? Then we'll have to mention for all the cranial nerves. I will address to the cranial nerve which I'm expecting to be involved. Therefore, I will say please let me make the point clear. All the posterior. undergraduate speaks in any way, I will not bother. He should speak. That's all. And I will pass him over. But for the postgraduate, your point should be intelligent, relevant to your case. You have some idea in your mind, not just you take it. That means suppose in which condition, presenting with this type of the disorder, which cranial nerves you are expecting. That I will say you should try to rule out or confirm whether it is there or not.
Sir, in our cases, mostly 7th, 8th, 7th nerve is most commonly involved, or 9th, 10th, and 12th, sir.
So that I think Dr. Dhanush has mentioned. Dr. Dhanush, I think I will not look at the chat box. Please make your video on. I don't want to discourage you, but I want to involve you. Anyway, then difficulty in closing the eyes. I think that is for 7th already you said. Drooling of eyelids and double vision. Jay, what is your idea? That's why in the negative history, whatever you mention, you should have the good, palatable, explainable explanation. Acceptable explanation. Right. Suppose here she mentioned there is no history of drooping of eyelids and double vision. So what she wants to exclude or confirm? Very simple.
Third no pulse.
Yeah, third, fourth, sixth we can say. Extraocular in short muscles involvement. She wanted to confirm whether these there or not. And in which condition it can happen? In which condition? That means, in one word, if I say it's an ophthalmoplasia. Which condition will present with the ophthalmoplasia? And this type with some weakness? Yes,
brainstem syndrome. Brainstem syndrome. Miller-Fisher.
This is another thing in the exam it happens so. Because your focus is to one particular condition.
Myasthenia.
Yeah, on the contrary, commonly it will be present with ophthalmoplasia. Is a characteristic of peripheral nervous system disorder, the myasthenia gravis. Of course, some other features will go in the details. Here also it can happen. You are not wrong. But just I wanted to confirm that what else you know. Diurnal variation of the weakness, Jay. She said diurnal of the weakness.
Myasthenia.
Yeah, very classically, if you ask the history of the patient, first they complain of the fatigability. Commonly even, non-specific complaint. And then fatigability, if you ask in detail, they will say that compared to the morning, person is better. As the day passes, probably fatigability develops, and the evening almost very big. And with that, suppose if you get the history of or something, probably hardly require the confirmation for the investigations. Many times, and if you get even the repeated history, again it strengthens your possibility. So that's the beauty of the medicine, that keeping in mind whatever the presentation of the patient, you will decide related information, put together either positive or negative, try to find out that how much it is strengthening your possibility, how much even the excludes in nearby differential diagnosis, and is there any expected complication or not. Keeping in mind these three things, you should ask the negative history. Please, this is very important. And I think last, even the throat pain and fever, yes, again, recent intramuscular injection or trauma, Richa, which intramuscular injection will present in this way?
Sir, any recent vaccination can happen, sir.
Which vaccine?
Or, sir,
let me make the point clear. Let me make the point. Let me be clear. Any intramuscular injection or specific vaccination? What is your point?
Sir, in traumatic neuritis, normally there will be weakness of the nerves.
In the traumatic neuritis, do you expect that it is going to be the bilateral? It is going to be symmetrical? It is a progressive? So why I should go there? I hear probably there is no point of thinking for this specific trauma, right? So I think which type of intramuscular injection is going to be present. Even somebody has mentioned DPT booster. Dr. Dhanush, come on. How the DPT booster will create this problem? Number one, always you are giving the question to this examiner. 8-year-old child, whether 8 years is the age for the DPT booster? No. Then my questions will start from the vaccinology. That DPT last booster is given at the age of 5 years. After that, you will have to go, then either the TDEP or DT and not the DPT. So there is no question. Therefore, as a candidate, even always keep in mind all the points, right? So intramuscular injection trauma probably present in this way is least possible. Not even I will say possible. In the past, what we were asking the history of intramuscular injection, that was with reference to the poliomyelitis. Now I think hardly even there is question of polio, but still if you are. But one more question I would like to ask Dr. Jay or Chandra, because she has mentioned this vaccine. Which vaccines are having association with even these GBS, Guillain-Barré, suppose? I think that you should verify. And it's very specific vaccines. They have identified some link between these vaccines and the GBS. Any idea? Any idea?
Hepatitis B, sir.
Richa, yes. Hepatitis B.
Hepatitis B.
And somebody,
Influenza.
Dr. Hardy, I know Dr. Hardy is, I will say, participating regularly and she's putting over the good comments. Influenza vaccine also, yes. Influenza. You should ask for even the rabies, yes. So I think with some vaccines, we have found out some association. Even nowadays, somebody is asking the history of COVID even. Probably that also we have got it after the COVID. Somehow neurologists have observed, and we are learning from them, that incidence of the immune disorders as a whole in neurology, more so in the GBS-like picture, is seen even. We are not sure, probably we don't have the exact established, I will say, data, but yes, that the observation of many friends, clinicians, particularly the neurologists. So we'll have to consider. So that's the thing that how we can consider. Recently, in which city of India there was some more incidents of GBS was noted or reported? General knowledge question. Recently, yes, Dr. Megha Vora, yes, very good, in Pune, right? And which particular problem they had some link or explanation that why the more numbers of GBS were recently reported from Pune? What was some conclusion? May not be the final conclusion, but yes, they thought of something. Because you are staying in this country and you should know the details of this country, what things are going on, particularly related to our science. Yes, Dr. Chandra. Pune, yes, but what was the link between the GBS and anybody knows?
Sir, Campylobacter.
Yes, how the Campylobacter they got it?
Contaminated water.
Yeah, that was the suspicious. Probably, I'm not sure it was proved or not, but they thought of there was some problem of the contamination of the drinking water and the sewage water. And following that, they suspected that probably Campylobacter may be the responsible for the increased incidence of the GBS and that of the presentation. You know, epidemiology of the country also we should know. For this, any type of the disease, and you know, that's why I said that not necessarily they are going to ask your case. They want to know whether you are aware of all these problems or not. And I think Richa has raised a very good negative points. Even snake bite is also very important. We should gather the information. As again, if I repeat it, negative history should be related to your case, to your probably your possibility. And presence or absence of that point either helps to consider or possibility, strengthening the possibility of your condition, or even the excluding the nearby differential diagnosis, or what common complications we observe. You want to verify that what is the status of the patient at present. That should be your idea. I think having this point, let us, before we go further, take a word from Dr. Anusha. Please, madam.
Hello, sir. Yeah. So what I would like to add is very clear, like very nicely, she has told the negative history. So when we go towards negative history, it shouldn't be very random. So once we are finished with the history of presenting illness, when we are telling the negative history, it should start in an order. First, you have to rule out CNS involvement, like your headache, vomiting, altered sensorium, and seizures. And then you can go towards the spinal cord, like your peripheral system. And spinal cord, as she mentioned, like bowel and bladders. Is there any
Dr. Anusha,
Yes,
can
sir.
you please continue for some time? I'm coming back. Meanwhile,
Sure,
you can
sir.
continue.
Sure,
Please,
sure.
please.
Yeah. Yeah. Then you go towards your spinal cord involvement, where you check with your bowel and bladder involvement. Is there any sensory involvement? Is there any back pain? And further, you go towards your neuromuscular junctions, where you ask, where in neuromuscular means you're suspecting something like your myasthenia, you want to rule out. So here you talk about your drooping of eyelids, double vision. Is there any diurnal variation of weakness? And like, is there any fatigability associated? And then you go towards your bulbar involvement, where you mention about your swallowing, chewing. Is there any nasal regurgitation, any change of voice that you have to rule out? Why you see bulbar involvement and your respiratory involvement is you want to also, along in your history, you want to also emphasize on the severity of the weakness and what considering this is a lemon weakness case, and what if this is a GBS per se. So is there any severity, like is there any bulbar involvement, is there any respiratory involvement? And how do we check respiratory involvement? In your history, you mentioned about the breathing difficulty, not just breathing difficulty, even like, is there any breathlessness while talking? Is there any weak cough associated? This is important to ask. Then you go towards your autonomic dysfunction, where you talk about excessive sweating, palpitation, dizziness in terms of autonomic and any heart rate variabilities. So you ask this in your autonomic dysfunction. And another like neuromuscular junction disorder which you would see is your botulism. So for that, you have to rule out your honey and any honey ingestion or any canned food ingestion. Is there any constipation? Is there any pupillary abnormalities? Then see, regarding the fever. So what she mentioned in the beginning, fever at the onset, it's very important, because it is an important history when you want to think of an acute myelitis or a poliomyelitis, where there'll be fever at the onset of weakness with the element presentation. As compared to your GBS, the fever history is prior. It's weeks prior there is an infection, not at the onset of weakness. So this is something important which you have to establish in your negative history. Then also you mentioned the animal bite causes. That is rare when it comes to your rabies paralysis. And last but not the least, metabolic causes. See, it is any acute illness we have seen. You also have to establish this is a monophasic illness. This has happened for the first time. Is there any previous similar episodes of weakness in the past? Or is it like an episodic weakness happening? This is also very important to tell. And also for your metabolic causes, one other important history which you can also mention is there any precipitating heavy meal before the onset of weakness, right? So this is why, because if you're to rule out hypokalemic paralysis, so that is an important history which you can also add on. And next, going forward to your myopathies, should mention, is there any associated muscle pain, or is there any dark urine in the history? So this will rule out your viral myositis, polymyositis, and rhabdomyolysis. So like this, in your history only, you can rule out all your differentials as you're presenting. That should, like, your differentials will not come after your examination. From, as sir mentioned, history is very important when you're presenting a case, and in your history itself you should have an idea of the acute what you're presenting, and then rule out all the possible possibilities in diagnosis, other differentials in your history, by taking a good negative history.
Absolutely.
Yeah.
Actually, what Dr. Anusha Madam said, I want to prepare the students in such a way that every examination you can answer at the end of history that this is my clinical diagnosis. Probably I should be right. Just for confirmation, sir, I will examine. Or even some dogmatic students, even suppose tells me in the exam that, sir, I don't want to examine the patient. I'll be happy even. Some really, if you have taken the good history, or you can even predict that on examination, what are the findings is going to be there. Even really, if you have taken the good history, most of the times you can say that before examination, I will write down my findings on the paper. And then I will verify that how many of these findings are present. Most of the times it is going to be there. To be really, what I say, the clinical medicine is so interesting. To be very frank, as I'm growing, I understand that probably I'm learning more. And that even increases your confidence that yes, sometimes your investigation, everything is important. Even advanced technology is important. But that proper utilization will have to learn, not at the cost of, I will say, the clinical medicine or basics. And if you go, I will say, for the advanced technology at the cost of the basics, that is dangerous. That is dangerous. But if you have, I will say, your basics are very good, and with that, even you are competent even to use this advanced technology, that's the best submission. And then you are going to be the, I will say, master clinician. So that's even again the message which we should do. Anyway, Dr. Richa, we have taken more time now. I think you can complete the history. Then we'll interrupt you at the end of the history.
The past history of flu, stool and fever before 2 weeks prior to the hospitalization. Fever was low grade and was relieved with medication in 3 days. Loose stool was 3 to 5 times, semi-solid in consistency, non-bloody, non-foul smelling, relieved by medication taken by private hospital. No history of previous hospitalization for similar complaints. Family history. The patient belonged to nuclear family with 5 family members residing at Pakka house. Mother's age was 28 years and father's age was 34 years. Pakka house, 2-room, well ventilated. Father has done his education still primary school, occupation semi-skilled worker, income of 20,000 rupees per month. According to modified Kupuswamy scale, lower middle social economical class. Separate toilet and bathroom was present outside the house, and drinking water from municipal tap boiled and stored. Antenatal history: spontaneously conceived at 20 years of maternal age, booked, and only 2 antenatal visits was done.
I think Dr. Richa, even in the exam also, if you want to save your time, probably an 8 years old boy with this type of the presentation, it has no any specific point or link with this antenatal nature or birth history. You can just answer in one line that I have gone in the details of this history, not any very significant point was noted. That's all.
Okay, sir. Okay, sir.
Then your presentation will be impressive, even quite lucid, and it will not be the boring to the examiner. You know, history should be impressive to the listener. That's very important. Okay, I think if suppose nothing is there, you can just keep it out with the one-line answer.
Sir, okay. Sir, as in my case, there was no antenatal history or natal postnatal history was uneventful.
Right.
Developmental history, sir, the child has achieved all his development milestones and was studying in 4th grade standard. Immunization, he was completely
the only, again, one comment for the developmental quotient. At the 8 years, what is important? DQ or IQ? What you should go? DQ is up to what age?
Sir, DQ is up to 5 years of age. And
so then, really, if you want, you can say that preferably, I will go for IQ, but somehow I have not gone for that exercise. You can mention in this way. And very important point, IQ or DQ, whatever the figure comes, is the plain figure. It's not percentage.
Okay, sir.
In mathematics, if you remember, any quotient is going to be the plain figure. Right?
Sorry.
Yes. So that's why what I will say, don't give any space to the examiner. You should be so meticulous that the examiner is trying to get some point, but not getting. Then I'm sure that is the impressive presentation. Very good. You are doing the good thing. Please take it further.
Yes. There was immunization was complete. Child was completely immunized up to 5 years of age, and BCG scar was present. Sir, dietary history. They were consuming 836 calories per day and 19 grams of protein, and deficit was 764 kilocalorie per day, and 10.2 grams per day protein was deficit, sir.
Right.
So, sir, summary so far, sir.
Can you stop sharing? Sorry, Richa, can you stop sharing?
Yes, sir.
I think your summary will take into consideration after the participation of other students.
Okay.
Yes, Dr. Chandra has some doubts. I have the doubt. What about the DQ in a case of? Okay, sorry, I missed it. You can ask the question. Yes, Dr. Indra, you are here. So you can ask the question. What is your question, please?
Yes, sir.
You have mentioned some question, am I right?
No, sir.
Okay, I
Sir,
think somebody else. Okay.
Yes, sir, Dr. Chandrasekhar M.
Oh, sorry. What is your
I have a
question,
doubt.
please? Yeah.
I have a doubt. What about DQ in case of CP if child is more than 5 years?
Yeah. I think Dr. Anusha is there, so I have also not to think even.
Yeah, what is the thing?
Can you repeat your question, please?
Yes, sir, I'll repeat it. So there's a question that what about DQ in case of CP if child is more than 5 years old?
See, if it is a case of developmental delay, you can use the developmental quotient. But clearly, this is a child with normal milestones. So in this case, you would prefer to use the IQ than a DQ. But when you're dealing with a neurodevelopmental case or a developmental delay case, there you can mention the developmental quotient.
Probably the reason is, that child will not reach even to the development.
Yes.
And therefore,
chronological age and mental age is different, right?
Yeah. In that case, you can go even the developmental, particularly age of that child, and then you can go in the details.
Yes.
So I think good question, but in the exam, there should be hesitation to any of you. Good. Yeah. Anyway, another point what she mentioned, that history of the loose stool and fever 2 weeks back. Is there any link to this problem? Dr. Chandra? Or I think Dr. Monica is from Jabalpur. Dr. Monica, am I right? Dr. Monica, are you there? Because now gradually I am knowing the students because they are attending from different places. Yes, Dr. Jank, what is your idea? What she had mentioned regarding the low stool and fever 2 weeks back?
Campylobacter jejuni, sir.
I think point is, Campylobacter, I don't know, and nobody has confirmed.
Good evening, sir.
Yes.
Good evening, sir. Actually, when fever 2 weeks back, and if the child is presented with a weakness after 2 weeks, the child we maybe think about the one is Guillain-Barré syndrome, and second one will be like a polio non-polio enterococcal
enteroviruses.
Yes, sir. Enteroviral infection.
Yes. Dr. Chandrasekhar is there. Good. Actually, what was my point to, I would say, Dr. Chandrakar, who was responding? Sorry, I think Dr. Jank was responding. Very difficult to say particularly the organism also, but very common GI symptoms or respiratory symptoms. History of even the 10 days, 2 weeks back. Any GI symptoms, particularly the loose motions or even the fever, like similar respiratory symptoms 2 weeks back. We know that particularly these organisms, these are not the infective conditions, but this particular infection later on went for the immune problem and even this mimicry of the molecular mimicry theory. Therefore, it presents with this type of the history, demyelination. So that's the thing that how we can correlate. So that's why what I will say, Campylobacter, yes, common organism, but we do not know exact the organism. But yes, having the loose stool, that means there was this very specific GI infection or respiratory infections, this type of the infection, and there people have correlated that yes, these infections are common, and following this infection, there is the immune problem, and this due to the molecular mimicry theory, very specific aspect of nervous system is affected, and then there is a demyelination, and clinically present the patient in this way. So that explanation is there. That's the thing that how we should answer. Very good. Rest of the things I think very nicely she had mentioned. What was my another exercise to all the students that it happens in the very commonly in the DNB and MD examination, that they will ask you the summary at the end of the discussion, history discussion. And that summary, Richa, should not be the repetition of the same things which already we have discussed. That summary should be your inference, your interpretation from this discussion. Or what is your inference? or try to prepare some hypothesis. But this is my likely thought process. And for that reason, try to answer 3 questions. Ultimately, with the discussion, how you decided or came to the conclusion that is it neurological problem? Then which part of the nervous system is affected? Central or peripheral? Suppose central, try to answer it. It's cortical lesion, it's a subcortical or coronary radiata, it's an internal capsule, it's a midbrain. In midbrain also you can go for the brainstem, pons, medulla, like that. And every aspect is very characteristic. That will guide you that should you consider which part of this involvement. Similarly, peripheral nervous system already we discussed, anterior horn cell, peripheral nervous system, neuromuscular junction or muscular. And then that is the anatomy you can try to answer. Second, what type of the pathology? And then possible common etiology you can consider. These are the common conditions. So that will be the good palatable, I will say, summary. Now, which two students should try to give the summary? And I wish that you should do in daily rounds these type of the cases. You can write down, I will say, being registrar, 3rd year. 1st year probably I may not expect, but 3rd year should write down the small paragraph that this is my diagnosis. Who will do? Anybody? Dr. Chandra, can you attend? Would you like to do? Please. Very good.
Sir, according to this case, the patient is 8-year-old male coming with complaint of acute onset, progressive, bilateral, symmetrical, polyneuropathy or polyneuroradicculopathy, especially reflex is not checked yet, but hypotonia is present, and sir, element kind of lesion mostly suspecting.
Okay. You know, certain things still you're examining, difficult to make the comment. You are expecting is a different story. Okay, but I will say it's a good attempt. Good. Anybody else? One more person.
Okay, sir.
One more person, anybody? Dr. Megha, I think you are responding very nicely. Would you like to put your summary in your own way?
At least try.
Yeah, you should try, Dr. Megha. Anyway, Dr. Jay is ready. Fine. Come on.
Yes, sir. An 8-year-old child presented with chief complaint of acute onset of progressive bilateral ascending type of paralysis with preceded an acute some kind of infection related to GI, which more proceeding towards likely to some motor nerves causing paralysis.
Okay, fine.
In the fully immunized cells.
Very good. I will say it's a good attempt. I will appreciate both of you. Simply, I think we can, that's another thing. Nobody can give the perfect diagnosis from the history. And that's why I said you can prepare some hypothesis. That this is my possible way of thinking. You can say that here 8-year-old boy has presented with the acute illness in the form of the weakness. We started from lower limbs, progressed to even the trunk and the upper extremity within the very short time in the form of the hours. And therefore, it is the ascending, progressive, rapidly progressive condition. Having this thought, even I verified that there is no involvement of autonomous system or other cranial nerves in this particular disorder. Going in the details, I got the point. The child had recently GI symptoms in the form of the frequency of stool and fever 2 weeks back. The rest of the history is not contributed in any other way. And if I come to the conclusion, it's a peripheral nervous system problem, very acute or hyperacute, rapidly progressive, in the form of the weakness, and therefore likely that may be the flaccid paralysis. If I come to this condition, most commonly 2 conditions will come to my mind. Several conditions are there, but the toxin and snake bite and everything are excluded. As Madam said, even there is no such history in the past, so it is not the periodic or episodic. So thus the whole group has gone probably from my mind, except it is the first time presenting to me, which I am not sure. And therefore, this, if I consider the two common conditions, either the Guillain-Barré syndrome or poliomyelitis. You can say that poliomyelitis is in this country last reported, Richa, when? While poliomyelitis reported in India, last case?
16th, sir, April 2016.
No. Sir,
yes.
Sir, I have a question, sir.
First let us finish this answer and then I will be coming back to your question. Chandra, do you know that when the last case of polio reported in India?
April.
Please remember that was the previous day of Uttarayan, therefore very easy to remember. Previous day of Makar Sankranti.
13 January.
And that was the 13th January. Somebody had put the right year, even 2011. And it was reported from West Bengal, Calcutta.
Okay, sir.
That was the first, and therefore you can say that last reporting from the poliomyelitis in this country is 15 years back. Probably gradually it is going down, but still probably vaccine associated we can consider one of the possibilities, but still it is not so common, and therefore even the clinical picture is also not suggesting it should be the patchy, asymmetrical, that is different thing, right? So that's why you can say that these are the various possibilities which I consider. And then I will go for the examination, right? So that's the point. Yes, Chandra, you had some question, please.
Yes, sir. You put two possibility in this case, sir, poliomyelitis and GBS. But, sir, polio has weakness with fever.
Yeah.
But she presented negative history, fever in the negative history, sir.
Right.
So polio is ruled out there, no, sir?
Yeah, that is another thing. In the medicine, never anything ruled out.
Yes, sir.
Even anything.
Okay.
When I was of your age, I was so dogmatic that I will say this is the only one possibility. But then gradually we learn in the medicine that if you have that habit, many times it will be wrong.
Yes, sir.
And therefore in the medicine, I think common that of the presentation, but you know, very, very often Dr. Ambedkar, you must have heard the senior teacher of this country. Ambedkar sir says that every patient or every disease has not read the Nelson.
Okay.
The point is every disease does not present typically.
Yes, sir.
What we are discussing is a typical picture.
Yes, sir.
But every disease may not have the typical picture. What
Yes,
commonly
sir.
we said when the Guillain-Barré syndrome can present, and I think at the last we'll go with the neurologist, that what are the abnormal or unusual, atypical presentations.
Yes,
and
sir.
even in those several times, I think Dr. Anusha will agree with me
Yes.
that even if we call them, some of our patients, they are also not able to answer. There's a difficult to say that it is not GBS and yes GBS. It happens in the medicine. Medicine is subject like this. And therefore what we say, it's a medicine is a subject of uncertainty and probability. Every time our uncertainty remains, we are not sure. But yes, probability is there. And from the probability, I will go further. If I confirm, if I fail, then I will go for the second thought even, that what are the differential considerations. That is, I will say, beauty of the medicine. So your point is valid. You can say that typically, commonly, this is the presentation of poliomyelitis. That type of clinical presentation is not there. Fortunately, now it is not common even, particularly the wild variety, and therefore it goes below in my consideration. Always answer in this way. Don't say that it is excluded. Don't say it is not possible. It may happen so that Richa's case may be reported in even world, that this is reported from India. It's right, we don't know. So that's the point, that how we should answer. But he has raised a good question. In the medicine, therefore, another thing in the discussion always go in such a way that it should be the convincing. You can say that polio, I will say, one of the possibilities, but even I will say it least common to me. You can answer in this way. At least commonly, you have the explanation. Clinical presentation is not there. Age is not there. Not reported since 15 years, particularly the wild variety. But yes, even the vaccine associated remain the possibility, and that cannot be ruled out. Good question. I think I'm sure that we have taken sufficient time in the history. But before we go for examination, anything from you, Dr. Anusha?
So we can proceed with the exam.
Yeah, I think we'll go for examination because we have taken sufficient. I think people take the 80% time. We have taken more than that.
Yes.
And I think it should be rewarding. Anyway, Richa, now you can focus for the examination.
Summary so far.
Okay, I think directly, Richa, can you go for examination? Because already that point we have discussed. Good.
Sir, according to my case, the anthropometrically, the and the height was
Richa, your voice is breaking. Probably there is some net issue.
And the BMI was also on the 10th to 25th percentile. Hello.
Yes,
hello.
Sir. Now it is clear. Please go ahead.
Sir, am I audible?
Yes, sir. Audible.
Okay. Sir, there were on general examination. The child was examined on the 4th day of admission. The child was lying in a supine position and was alert and oriented to time, place, and person. The child was undernourished and there was normal hydration status. The parameters of vitally, the child was stable, and on general examination from head to toe, there was no clinical any significant finding was also present, sir. According to my case, as we have seen so far, peripheral nervous system and the nervous system was involved. So I would like to examine the nervous system in more detail. Higher mental function. At the level of consciousness, the child was awake, alert, and oriented to time and place and person. There was no behavior disturbances was noted, and the child was interested in surrounding, and no sleep disturbance was also noted. Speech and language was good comprehension, good fluency, and child was able to repeat words. Both recent and remote memory was intact, and concentration span was good and able to sustain attention. On cranial nerve examination, there were no cranial nerve involvement was seen in our case, so I would like to go for motor system examination. On the basis of motor system, there was inspection. The child was lying in a supine position. No hypertrophy, no muscle, no atrophy and hypertrophy of muscle was seen on the both sides. On tone of the muscle, on palpitation, the muscles was feel flabby and soft. Posture was lying in a supine. Child was lying in a supine posture, and no on inspection the limbs were hypertonic. Flabby test was positive. Lower limbs, severe hypotonia was present in both limbs, and range of movement were increased. In upper limbs, mild hypotonia was present in both limbs symmetrically, and range of movement was also increased. Power, according to MRC grading power, they were on the upper limbs, shoulder joint, 3/5 was involved, and on the wrist and the elbow joint, 2/5 was involved. And in the lower limb, symmetrically all the muscles of the lower limb, 1/5, there was power of the muscles. Reflexes. In our child, superficial reflexes, corneal reflex, conjunctival reflex, and abdominal reflex and plantar reflex was normal. Deep tender reflexes were, sir, on the triceps and biceps, 1, and the knee and ankle, it was absent, sir. Sensory system examination. There was no sensory system was system involvement. Child was able to appreciate all the senses, sir. Cerebral examination, no abnormal movement was noted. No posture abnormality was present. Posture abnormality was present due to marked hypotonia. Formal coordination tests were difficult due to motor involvement, and gait and stance was also not able to appreciate. No signs of cerebral involvement were also noted. Meningeal signs were absent. Head shape and size was normal. There was truncal muscle hypertonia was present. Single breath count was 22, and there was no spinal deformity, tenderness, or no tuft of hair was seen on spine. Other system involvement. Cardiovascular system examination, S1 and S2 heard, and no murmur appreciable. Respiratory system examination, bilateral air entry was present. Normal vesicular breath sound was seen in all the areas, and no adventitious sounds were noted. Abdominal examination, soft, non-tender, and no palpable organomegaly was seen. So summary and clinical diagnosis. 8-year-old child with developmentally normal presented with the acute onset of rapidly progressive weakness, which was symmetrical, ascending in nature, involving both lower limbs and progressive to the upper limbs, with absent deep tendon reflexes, without sensory involvement, and no involvement of bladder and bowel without involvement in a bladder and bowel. Hence, from examination and history, possibly suggestive of radiculoneuropathy due to inflammatory demyelinating, that is Guillain-Barré syndrome. And
okay, can you stop sharing?
Yes, sir.
I think first in the exam also, after the examination, put the positive findings on the paper. It is good habit. Whatever you have observed on general examination, and always in the, even suppose the short case is given to in the exam of any system, relevant point in the general examination should be always checked for. Suppose the case of hepatosplenomegaly, you should not miss suppose pallor or jaundice or something, because these are the related points, even on general examination. Therefore, even general examination findings related to the system in the short case I am talking. In the neurological, which is commonly the long case, nothing should be missed. Nothing is optional. That's very important. On the contrary, try to check very specific points on general examination, whether they are there or not. Because somebody is going to ask, Richa, suppose directly if I ask you that with this type of the presentation, what points you will check on general examination? That means what is expected. And you will verify, is it there or not? What are the points in this type of the case? General examination, I am talking.
Sir, in this system, sir, mostly in first we will see the vitals, sir. If there is autonomic...
In vitals, what problems you are checking, verifying, and some presence or absence will make difference in your, I will say, prediction.
Sir, in vital system, we'll check for the autonomic
Suppose, Richa, I will ask you the direct question. Probably, suppose if you have diagnosed that this is the possibility of GBS. And now I'm finding that the patient remains the fever. Suppose my resident informs me that the child has the fever and significant 100, 101. That means febrile child with a diagnosis of even the GBS. How does it make difference in my thought? That's the point. I think that's why I will say postgraduate should be prepared with very specific situation. Commonly, I think in GBS, I don't expect the fever. Am I right? And already you mentioned that I don't expect that the child should be febrile unless some complication, pneumonia or something. It's a different story. Suppose this complication is not obvious, but still the child is febrile. How I will say, I will explain, and how much I am concerned. How it, I will say, make difference in my thought process. That's the point. Any point, Dr. Chandrak, any idea? There's a very classical patient of the GBS where I don't expect the fever, but unfortunately this child has the fever and no obvious cause of fever. That means nothing else. There is no UTI. There is no even this pneumonia. But just fever is there. As autonomic nervous dysfunction, but the rest of the suppose autonomous nervous system disturbances are not there. Isolated fever, I will say, with autonomous is less likely.
Maybe, sir, due to pain.
Sorry?
Maybe due to pain, sir.
Sir, muscle fasciculation.
Pain is not going to cause the pain, I will say fever. What parents are explaining me. Many times the parent will explain me this, that fever is due to the pain, due to some fear. due to some exam tension, right? We know that it's a different, it's not, and everything suppose it has caused, it is again autonomic nervous system disturbances. You know, it's an immune problem. That is another thing. And really the fever is there. I will predict that still immune problem is going on. And it may even, I'm more worrying for the prognosis point of view. That may not be the good or the favorable prognosis if the fever, significant fever persists without any other reason but just immune explanation. You know, that's, I will say that as a postgraduate, how we should. Second thing, right, like that. Of course, fever, even you can check other things and other reasons can also be there. Similarly, pulse. Pulse, again, it will suppose tachycardia, flushing. That is another thing, autonomous. Blood pressure, always you should check. Not even the on admission, later on also. Particularly for the hypertension. Or even the labile blood pressure. And that can happen with the auto nervous system disturbance. Why I will say we are discussing so much with the auto nervous system disturbances in a case of GPS? How much we are concerned? Why we are worrying?
Sir, there are cases, sir, seen that in which rarely there causes autonomous nervous system involvement. It can cause hypotension, sir, and it will predict the outcome, sir.
What outcome? Like, yes. You know, we are with the presence of the auto nervous system disturbances. I can predict that the prognosis may not be favoring. Every patient does not go for the serious complications. But from that group compared to another group where the disturbances are not there, it makes difference. Therefore, we are more worried. And therefore, we should daily check that something, the excessive sweating is there, flushing is there, tachycardia is there, hypertension is there. Then you should check it. Very important thing, I will say, suppose in the OPD, this child even can happen because it is rapidly progressing. What happens to the respiratory system? Even they may not complain, but daily my vision should be there. I should check.
Sir, for accessory muscles involvement, sir, if it's there or not, sir, if there is tachypnea, sir, or extra respiratory muscles involvement is there, sir.
What type of the presentation? You know, this is the theoretical explanations. What happens to the patient? What I can see with the patient. And as a clinician, or I will say being a resident, what you will observe. And that's what, you know, and even gradually we should develop our clinical acumen also. That suppose the patient of GPS, what specific points you will check. Or even you can ask the sister on phone, suppose if you get the call. Respiration point of view, you know, weakness of the respiratory muscles, what is expected. And with the respiratory muscles weakness, suppose particularly the intercostal muscles are weakness. And suppose only diaphragm is working, there will be the only diaphragmatic movement. And therefore, many a times, even suppose diaphragm is particularly involved, there will be the paradoxical respiration. Right. And single breath count, I go for assessment of the weakness of the muscles. I think single breath count, somebody is going to ask, it's a good clinical, reliable, I will say, sign. And very important point, you know, what is the, I will say, master of the clinician. Suppose if you are noting the single breath count, which was normal, suppose initially, now it is affected. May not be the clinically to decide the weakness of the muscle, but it indicates to me. And suppose again, evening, if I say dropping, please find out that this patient may require the ventilatory support at any time. If you don't have the facility, find out the place where the facility can be provided. That's, I will say, difference in the clinician. Because we are predicting that this is going to possibility of developing this problem or complication. So that point, I will say, in the general examination, then even the support patient is having for longer time, even in the, sometimes it takes even weeks together, then the bed sore and so many other issues, problems can develop. Even you should examine the bladder. Parents have not completed, but you will find that, oh, bladder is full. Involvement is there. There may be the constipation, child has not passed the stool for the very few days or so. They may not complain, right? So what I mean to say that as a clinician, you should know that with this particular situation, what other things should be checked. Yes, as you said, even the cranial and everything, you are going to check it. That is number one. Second, then put the positive findings on nervous system examination. What are your positive, which I will, to save the time, directly I will interact with you. What are the positive findings of nervous system? I think in only one breath you should mention. Now I am asking for you one breath.
Sir, in our case, there was a hypotonia was present, sir, and on power of the muscles, sir, mostly the lower limb power was more affected than the upper limbs, sir, and in upper limbs also the distal muscles were more affected than the proximal muscles, sir, and on the basis of reflexes we can see that the superficial reflexes were normal and the deep reflexes were involved, sir. And deep reflexes in lower limbs, the deep tendon reflexes like knee jerk or knee jerk and the deep plantar reflexes, sir, they were more involved, sir, in our cases. Like they were absent in, sir. So, sir, and to that we can predict that it was lower motor kind of more lesions, sir. And sir, on there was no cerebral involvement was seen in our cases. Sensory system was intact, sir, and the spinal cord or there were no meningeal irritation and meningeal signs were also seen in our cases.
Can it happen in a GBS?
Sir, due to neck muscle involvement.
Richa, always, I want to train all of you. Address the question, answer perfectly. As I said, whether the signs of meningeal irritation in any situation, can it happen with the GBS? Yes or no?
Sir,
yes, sir. Yes, sir. Sir, due to radiculopathy, back pain is present, so sometime...
No, I'm asking you not the back pain. I'm asking very specifically signs of meningeal irritation in the form of the neck stiffness or Kernicks positive. Can it happen in the case of this GBS, yes or no?
Yes, sir.
Okay, then what is the explanation?
Sir, due to radiculopathy, sir.
Rather than something else. Radiculopathy, it's a only peripheral, even it is going to the back. Sure, once you say signs of meningeal irritation, that means there is inflammation of this meningeal. Right. And can it happen?
Yes, sir.
Yes, meningeal irritations. Dr. Megha is answering on the chat box but not speaking. Anyway, that is her way. We'll appreciate. But what is the explanation that why it happens so? Suppose if I help you, in the exam, some examiners are helping, and I'm one of them. So I will say, okay, it can happen. Signs of meningeal irritation can be present. Then what is the explanation? Then what is the explanation? In other way, if I ask you, can it cause even this meningoencephalitis? Yes or no? I think
yes,
if you don't know, we have the expert. You can ask Dr. Anusha. She will guide us. Whether in any situation may not be the common, but whether the sign of meningeal irritation can be present and what is the explanation. Dr. Anusha, can you help us?
Sir, rarely it is possible, sir. If like as the antibodies are produced, if it attacks the meningeal layer as like how it is attacking the peripheral nervous system, like your aseptic meningitis without any acute infective cause, it is rarely possible that it can coexist, but it is not a common thing.
I will say, Richa, you should answer this question. Commonly, no. But occasionally, yes, it has been reported.
Yes.
That means so common that some people have observed. It's not so common. That's why I'm again repeating, be so competent, I think, the exam that your score should be good. Go with that preparations. And once you are answering in this way, you can say that Yes, it can. Commonly, no. But yes, it has been reported. And therefore, very clearly, that it's rare. Right? Like that, it should be. I think very, you can put the summary in this way. I will say positive findings. That on CNS examination, higher functions are, and that should come in the chronology. Higher functions are found totally normal, cranial nerves normal. Motor system point of view, I observed generalized hypotonia, generalized even diminished dependent reflexes, and even the power is significantly affected from 1 to less than 3. Signs of meningeal erosion absent. Rest of the findings of examiner system was normal. Of course, I could not examine the gait, but skull and spine were normal. Bladder and bowel involvement findings were not found. So I think, very, very clearly you are mentioning. And of course, last, even the point that no point suggesting the involvement of autonomic system involvement. So very clearly that means without problems and complications, you are present in the case, right? Because I think we have some time. Let us, I will say, come to the very specific questions which may be helpful to the students. Because please remember, if this type of the case is available, may not be so acute, but already GBS settled down, they may keep in the examination. In one line, you are suppose which I have to answer, you can say this is the case of acute flaccid paralysis, AFP. Richa, what you have done, suppose after this patient, what you have done specific related to this patient?
Sir, when the patient came, we admitted in this patient in PICU, sir. There, sir, first, after examining the patient, sir, first we asked for the blood samples were also given, sir, and then
please come to the very specific aspect so that we can save the time.
Sir,
suppose you wanted to confirm the diagnosis. Right?
Sir,
for confirmation, what you have done?
Sir, MRI, brain plus spine.
Please, number one, I think we'll go at the end to Dr. Anusha, but probably no test is required for confirmation, no investigations is going to confirm. Yes, it is suggesting some of the things you can do, right? Early, I think let us take the help of Dr. Anusha so that we can save the time and her expertise will be available to us. That what investigations we should plan, if at all, and what is the importance of the investigation, madam, please.
Yes, sir. So clearly it is a monophasic illness with a weakness, which is the ascending, bilaterally symmetrical ascending weakness with areflexia. So this is the clinical and examination-wise diagnosis. So moving forward to confirm the diagnosis, as you know, there is a diagnostic criteria. So you can do a CSF analysis, which has a specific finding. I think if any of the postgraduates know, they can tell.
Right.
So this
cytoalbinological dissociations.
Yeah, albuminocytological dissociation will be there. There'll be elevated proteins. And next will be your nerve conduction study. Have you done nerve
I think before Madam takes further, somebody is going to ask the question. Dr. Jank, I think you are trying to answer. Why there is this albuminocytological dissociation? Is there any explanation why it happens so? I think by that meaning that protein is raised and there is no cellular reaction or mild cellular reaction. That should be clear in your mind. So why this dissociation happens? Is there any explanation?
Sir, there is no infection so sir, neutrophilic count is low, sir.
Then why the protein is increasing?
Sorry, sir.
Richa?
Sir, the permeability of the increases, sir. So the protein
permeability of
meninges.
Yes, Dr. Megha, she is responding.
Permeability of meninges increases due to inflammatory reactions.
But Megha, where the meninges are there? Very good. I want to encourage you. Do not want to discourage. So please, your answer is right. But where is the manager? Please remember to save the time. Very characteristic, you know, that these, what we say radiculopathy, commonly what we are discussing, that is the nerve root. And that is the characteristic of this disorder. Now that is the extension of the nerve sheath, if you remember, which is the part of meninges. This, due to the inflammation, there is change in the permeability. And therefore, protein part increases, but there is no infection, and therefore there is no cellular reaction. Or if cellular reaction is minimal due to the immune mechanism. And having this, I will say, change in the permeability of the nerve sheath, which is extending over the nerve roots. This very, because you know, this is a very characteristic with the GBS. Hardly we get in other conditions. And this is the explanation somebody is asking. I think we should. And it is said that about more than 50 cells probably think something else even. Or even the neutrophilic cells, then also not palatable with this diagnosis of GBS. So small points you may remember. Please, madam, take it further. Sorry for interruption.
Yes, sir. So I wanted to ask, did you do a nerve conduction study in this case?
No, ma'am. Actually, nerve conduction study was not done. But we actually, as patient was, it was more progressive in nature. Okay. Yeah, ma'am. So we just had in our institute facility, we have MRI with us. Like, so we did MRI. And
do you think when you're suspecting an LMN weakness, MRI of what part you did? Like MRI spine or brain?
Spine.
Okay. So you did an MRI spine, it was normal.
No, ma'am. It there was a involvement of quadra equina region nerves were slightly inflamed, ma'am. So yeah, ma'am. So and according, like, from clinical diagnosis point of view, so ma'am, we started the treatment by giving IVIG, ma'am.
Okay. And nerve conduction study, do you think it helps in this case?
Yeah, ma'am. It helps, ma'am.
Okay, how would you like? So it basically a nerve conduction study will help you to know if it's a demyelination happening or if it's an axonopathy, right? So if considering if it's a demyelinating case, you have specific findings in your nerve conduction study, like your prolonged distal latency and your slowed conduction velocity. F wave abnormalities can be there. There can be a conduction block. So these are certain findings. See, if it's a clinically classical case, you will not wait and waste time doing a nerve conduction study or your CSF analysis. If it's a classical case, you go ahead. But if there are atypical presentation and you want a supportive, along with your clinical acumen, you want a supportive evidence to confirm GB syndrome, that is when you go for this nerve conduction study or your CSF analysis.
I think please note the one statement what the madam made, and very important not only for the student but the clinician, that once you diagnose the Guillain-Barré syndrome clinically, probably there is no need to go for confirmation by the various investigations. Yes. And the point is, if you go for the investigation, okay, but don't delay the treatment. Yes. It is very important message that always fairly good clinically, if you are, and you know, if you listen to madam, I was listening to her, what she mentioned clinically, that if it is the bilateral, if it is symmetrical, it is the lower motor neuron type of lesion, hypotonia with adiflexia. That is the very classical picture of the GPS. And if you even see the course of the disease, that is happens so, it remains the static for sometimes few weeks, and then starts a gradual recovery. Even in the course of disease also, if you know, probably this type of the course even does not require any confirmation, even whether it is helping or not. So again, you know that a clinical observation is very, very important. But what the madam saying is very important, that fairly good if it is convincing GBS, please don't wait for confirmation, at least don't delay the treatment. That is very important. Please, madam, for the sake of student and to bring their, I will say, idea, I am repeating.
Yes, sir. Sorry, sir, I didn't get your question.
No, already I think then the treatment point of view, what they should go.
So treatment, like I would like to ask, how did you treat this case? Like, what was the treatment you used for this case?
Ma'am, we gave IVIG, ma'am. 2 gram per kg, ma'am. We were given 1 gram per each day. 2 days we have given.
2 days,
And ma'am,
right.
there is no. Yeah, ma'am. There is no typical treatment for GBS, ma'am. Only we can give supportive treatment. If there is pain, we can give and physiotherapy also.
Then
we can start.
how the GBS helps? Sorry, immunoglobulin helps. Then why you are giving this immunoglobulin? How it helps in the case of GBS?
Sir, as it is a sir, the IG, IgG, sir, as there's mimicry and antibodies are formed in sir GBS. So by giving IgIg or IVIG or plasmapheresis, we are trying to
neutralize.
Richa, both the modalities are functioning in a different way.
Yeah.
In the plasmapheresis, we are removing these antibodies. While in a case of by giving the immunoglobulin, you are blocking them to act on the myelin sheath, right? Because it has to act with the IgG, and therefore we are blocking them. While in the case of plasmapheresis, we are removing from the circulation. These are the differences. And what dose and everything you said, I think previously we are going 400 milligram for 5 days. Nowadays, I will say neurologists, we are learning from them. They say that even if you give the single dose or 1 gram for 2 days, almost whatever the regime you follow, almost they are working similarly, and therefore that is the recent recommendation. Right, madam?
Even IVIG and plasmapheresis both are equally efficacious, sir. Depending on the center where we are.
Facilities available,
Facilities available, we can choose either
But
one.
the only one thing what the people say, that suppose already you are given the immunoglobulin, then it's not, I will say, a wise step to go for the immediately the plasmapheresis. Because by plasmapheresis, you are removing your own immunoglobulin which already you have given.
Yeah.
So that is another thing that, and suppose if you want to go somewhere probably together, they say always try the suppose facilities available, plasmapheresis first. And suppose if you fail even, or if you are not happy, and if it requires even in some cases, you may go for the immunoglobulin. Then I think, madam, people say refractory to the immunoglobulin. What is that terminology, or not responding? Then second dose should we go, and then what are the guidelines for second dose or so?
Sir, usually once we give immunoglobulin, we wait, sir. Usually the response will be there in most of the cases.
Yeah.
And as you said, if preferably if there is a facility for plasmapheresis, we try plasmapheresis first, so that if there is not, if there is, as you said, if it's a refractory, it is easier to give an immunoglobulin after that.
Yeah.
But on the contrary, if you start with immunoglobulin first, then you wait for at least like 2 weeks, at least you wait, and then you think of 2 to 3 weeks, and then you think of a secondary dose. But ideally, it is a monophasic illness. It will respond to the first early started immunomodulation. It will respond.
As madam said, very important that second dose usually people don't recommend.
Yes.
Very few cases what the neurologist mentioned that if at all, if you think for the second dose, that is not before the 10 days to 2 weeks time. I think Dr. Sandeep raised the question. May we have some question? Dr. Sandeep, please.
Yes, sir. I was initially questioned what to do, first plasmapheresis or IVIG.
Yeah, already madam discussed that.
Yes. So I lower the hands. And second question is also how many times we can wait after giving the immunoglobulin. If patient is progressive after giving 1 to 2 days, then we send for the plasmapheresis, or can we wait for 14 days?
Usually the people, I think let madam answer. She is the right person.
Sir, usually if it is a pure GBS case, it's a monophasic. It will respond. If it is going for a downward and again you are having a secondary increase in symptoms, then you have to rethink, are we missing out on something? And then it won't be a pure GBS case. It will be an atypical presentation. Then you wait for 2 weeks, and then you give a second dose, but then you're also reconsidering your diagnosis at that point. Because pure GBS will not have a vaccine.
One query is there. Sometimes patient is not ready for the immunoglobulin in periphery, in like my place. There is so many cost. so many cost of immunoglobulin. So can we give methylprednisolone in this patient, and is it beneficiary initially when we can send for the
Dr.
immunoglobulin?
Sandeep, I think madam will answer one question, one line answer even. What is the role of steroids in the GPS?
No, sir, there is no
That's
role.
why I said answer will be very short and one.
No
But
role.
no role of the steroids in the GPS at present.
At all, there is absolutely, as compared to your other autoimmune encephalitis, everything we can say, but here no role.
What I say, madam, in periphery, there is a patient shift after 4 to 5 hours of the traveling. It is beneficiary to give that patient, or can't we can't
not
give?
to any patient, Dr. Sandeep.
Okay, yeah,
There
sure.
is no role of on the contrary, by giving the steroid, probably we had some more problem.
Okay, okay, sir. Yeah.
So at present, very bold answer is there in every textbook, and even from all the neurologists I am learning, even Richa Thaddanee, that there is no role of the steroids in the management. I think the past we were doing, even I also given in the past.
Yes, sir. Yes,
but now very clear, and recently probably there was good article. They have mentioned all the trials.
Yes.
Clearly concluded that is absolutely no role of steroids.
Yeah, because of sir said before 10 to 15 years we are using methylprednisolone.
I think Dr. Sanjeev, can you mute yourself? Please mute yourself. Dr. Sanjeev, or I think host is able to manage.
Dr. Sanjeev Nehal, please mute yourself.
I think Lata will have to come to rescue to us.
Yeah.
Anyway, so I think these are the very important questions. Even the some people will ask, are there any bad predictors for the prognosis?
Obesity, sir.
Very good. Please remember, in a GBS, even the obesity, and nowadays obesity is not so rare. I remember that before I left or I retired from GCS Medical College, we lost one adolescent with some 60 or 70 kg weight, and with the GBS. And you know that nowadays, so obesity is the bad predictor. What are the other bad predictors for the GBS? That also as a clinician we should know, because these are some points from which you can predict that probably you may find that. Yes, Dr. Megha Vora has already used fever, yes, presence of persistent fever, particular neutrophil count.
Involvement of respiratory muscles, sir.
Okay. Still, particularly already we discussed several times, nervous system disturbances. It is also not having the good, compared to both the groups. Problems are more with this group. Is there any, I will say, question for the madam, is there any repeated or the recurrence of the GBS is known? Episodic. May not be episodic, but repeated.
Yes.
That means once happened, we treated, discharged, and again after some time came back with the classical GBS.
Can happen, sir.
Yeah.
Yes. After many years, it can happen. Not in the immediate phase, but yeah, it can happen.
Again, we can answer in this way, Richa. If suppose a question arises, not so common, but yes, has been reported.
Yes. Severity is always less, I think. Severity is less than previous.
Severity is less.
Yes.
So I think many more questions are there. Very difficult to. I think one. Yes.
If ma'am recurrence is there, then what should we are careful, and any further investigation in this patient?
Sir, if after many years, if recurrence is there, you treat it like if it is classical history, you treat it the same way. No need to further investigate. Only if it is in some atypical presentation, we need to look into it.
Yeah, and then another thing, even you may keep in mind whether any other autoimmune disorder is associated with this problem.
Right.
Autoimmune, some other disorder.
Autoimmune can always be, they have a propensity for other autoimmune, so we need to keep a watch for that.
Anyway, I think we have crossed.
And one small thing I would like to add,
yes, madam. Yes.
For the benefit of postgraduates. So I would also like to mention, always in GBS, we need not, like areflexia is not a mandate. Sometimes in early, like your Aman variant, like acute motor axonal neuropathy, initially your reflexes can be preserved in the initial part. So areflexia is not a mandate. And also like symmetrical weakness, what we say, it can, in atypical cases, it can present in an asymmetric way. And pure paraparesis variants are there. Like as you said, sir, atypical Miller-Fisher variant is there. and that facial diplegia, only like cranial nerve involvement, facial diplegia variant can be there. Then your pharyngeo cervical brachial variant. Like these are the various atypical presentation of GBS, which is for the interest of postgraduates. You can read about the atypical presentation. Yeah.
Dr. Richa, one thing is very mandatory for all of us. I hope in this case you must have done. And what is that thing? What is expected from you?
EMG inhibitor.
Yes, Dr. Madhuri speaking. Am I right?
Sir, surveillance, sir.
Yeah, AOP surveillance. Have you done, and how will you do, Richa? You can just describe. And I think every pediatrician of this country should know. The reason is my asking question, not just for the exam point of view. I think every consultant, every pediatrician, on the contrary, I would say not pediatrician, any physician, even neurologist should know, and mandatory that we'll have to follow. Now you answer, please, what we should do.
Sir, 2 stool samples should be collected, sir.
You know, sorry, Richa. You know, we are not going to collect the sample.
Yes, sir.
So you have to inform the authority.
Inform
right?
to the authority.
And then they will come within how much time?
Sir, preferably be within 24 hours, sir.
Yeah. 24 to 48 hours, preferably 24. You are right. Yes, then the 2 samples. What should be the size of the sample? Stool size?
Sir, 8 grams should be there.
Very good.
Thumb size should be.
Very good. Yes.
Sir,
and how will you send your transport even these samples?
Sir, in cold chain, sir. Sir,
okay.
Sir, the degree should be around 8.
You know, it is called a reverse cold chain.
Reverse cold chain,
right?
Reverse cold chain.
In the vaccination cold chain, that means from the site of manufacture to the point of use. Here, from this we are in the reverse direction we are sending. Therefore, reverse cold chain.
Reverse cold.
And then what they do?
Sir, they look for the any vaccine associated polio virus.
They will identify the polio virus. Then they will go for strain. And then they will go for the serotype. And whether it is the wild or even the vaccine associated. Then even the 3 strains. So you must be knowing the type 1, type 2, and type 3. Yes, right? Sir. Type 2, even I think for after 1999 in this country did not see. Yes, and then whole discussion may come on the polio vaccine, injectable, everything probably we should know. But this AOP surveillance should be done. What is the, up to what age it should be done? Is there any age limit?
15 years, sir.
You are asking the question or answering to me? Some smart students will answer in this way. If the correct answer, consider the answer. If incorrect, give me back to me. Yes. Commonly, that is up to 15 years, but not Dr. Raju 18, 15 years. But if you are even fairly good point to suspect polio at any age, even adults, even at any age you can. And it should be not to miss even slightest you have the point of the lower motor neuron type of lesion, even facial palsy. You should send such, I will say, patients for the AOP surveillance. That is very, very important. So many things I will say in the Viva how it takes place, but from exam point of view, I will give the idea. AOP can be the short note even in the MD examination, or even you should prepare for this, even the Viva also. All the details of the vaccine, status of OPV, what we are following, I will say fractional IPV, then the full dose, what are the recommendations, what the people say confusions, but there is no confusion, very clear why we are following, why we are not following. So I think this is just to give the idea, because it is going to be there in the exam. It depends upon the examiner, his choice, his ideas, that any question, Pandora box will open, and then we'll have to answer. Anyway, I think before we end,
Sir,
yes,
I give one once before 2 years we have seen GBS. Only ophthalmic involvement is there, sir. In a week there is a 2 to 3 case I have seen before 3 years, sir. Only ophthalmic involvement is there, sir.
Yeah, as Madam was discussing, there are even so many atypical varieties are there. And that we should know. And therefore, I will say we are finding the difficulty. That's why I said sometimes even neurologists also, may not be able to make the sharp demarcation. There is a clinician will have to consider that what does it favor, and then we'll have to manage the patient. But if you are aware, I think that best we can manage it. And this story is not from here, from the history. You know, what is the actually Guillain-Barré? What is the original name?
Lauren.
Not Lorraine, something else, but I know that you are knowing. You know, sometimes in the exam, I will say to my co-examiner that she's knowing. Yes, Dr. Jay
Laundry
put Landry.
Guillain-Barré.
It's a Landry's ascending post-infectious polyneuritis, what we used to say. Landry was the first person. Somehow his work was missed in between. Guillain and Barry, actually, I don't remember, one of them was his student, but then student overcame and his name was established. But even the history, if you see, some people say that it's the injustice to the Landry, and therefore many people say at present even, Landry's Guillain-Barré syndrome, post-infectious ascending polyneuritis. That name is given. Very interesting, those who are interested at Guillain and Barry, who were there, what is their contribution, who was the person to give the, I will say, cyto-albumino dissociation, what was the discussion on that aspect. It is very interesting to learn, those who are interested in the history, even the medical history. Anyway, almost it is 11, so it's, I will say, read signal to us that we should end over here. But I'm sure that, let me appreciate Richa, you have number one, you selected the good case. This type of the case is good for our learning. And even if you have learned a lot, we can help the patients. Even from your exam point of view, such patients possible that you may get it from that point of view. Second, I will say your presentation. Always I tell my co-examiners that she is talking to us after 3 years of the residency. And the person like me, I'm talking after 40, 45 years of learning. So there is always difference. And try to recollect that what you were doing when you were of that age. And therefore, I will really appreciate that your way of presentation, your, I will say, your tone of your colleagues, even Chandra, Jayank, Jay, even Mega was silent, putting on the chat box due to some background noises. He gave the clarification, but I will appreciate all the students. On the contrary, I want to be very frank, not just a case discussion or one particular situation or so. I wish that all the participant students should learn even how to speak, how to present, how to participate, how to even to answer. And I'm sure that if you start from this age, I'm sure that when you grow, you'll be able to do fantastic job. But you know, at some point we'll have to start. If you don't start, then you never start. Because then you have the reluctancy, hesitancy, and that remain. And then as seniority is there, more hesitancy, reluctance will be there. That now I'm assistant professor, now I'm professor, if I ask, does not look nice, or some senior pediatrician. And you know, but still I will say some people, even at any age. But that is very important, which I wish. And if you do the multiple time presentation, if you do even the multiple times, even the participation in the discussion, I'm sure, and I know that all of you have the good potentiality. There is no doubt for your potentiality. Certainly it is there. And therefore I will say the teacher, I will say in the presence of other teacher, just I'm speaking and taking the liberty, that it is our duty as a teacher even to encourage the student and to become the role model so that they can follow us, and tomorrow they are going to be the, I will say, good clinician. Of course, at one particular condition or discussion is the illustration. You know, something is required for our discussion. That's why we selected this case. But our idea is to go beyond that, how to learn the clinical medicine, our thought process, how even we should best manage the patient, and even how we can learn our academics, even how we can participate, even our publication or even the community. And that's why I will say, as you become the senior, write down the books, your ideas, whatever the things. And that's the thing that how it starts. So thank you very much. We'll end over here with this remark. And again, I will even appreciate your mentor, Dr. Rekha. I know that Madam had even in the few weeks back also the good case selection and presentation. And you know, it is said that when the student is speaking, always I say it is reflection of the teacher. that how much the teacher has really played the role. I understand that to prepare the students for this type of to give this courage or strength, the teacher has to work very hard. Then and then it is possible. And therefore, I will say really it was good. All of us enjoyed. And as presence of Dr. Anusha made difference in our learning. She contributed a lot in our understanding. And in a long way, all of us are learning. Thank you very much. We end over here. And
Thank you, ma'am.
I will say over to Dr. Lata and her
Thank you, ma'am.
Thank you, ma'am.
Thank you, sir. But the best thing regarding today's discussion was students were actively participating. That's a very good thing I felt. Over 3-4 months, we have been progressing. They are more, they're becoming more interacting. That's a very good thing.
To be very frank, Dr. Lata, sorry for interruption. This is the online discussion. If physically I am present, I am going to make them to speak. You know that when I am taking the PG classes, I don't sit, I will say, anywhere on the chair also. With the mic, I will be moving around to them and at least to speak. And you know, really, then all of us are learning a lot. Already, I think our President, Madam Neelam Mohan, has planned this type of the discussions zone-wise, and I'm sure that it will be very good learning for her. But as you say, many students participate. And even one more point, I noted that the students who participated in the past, even some of them were there. Even I think Dr. Monica, because now I remember she was from Jabalpur. Even Dr. Megha is also probably previously she was there. So many students are there. So it's a good thing. It's a good participation. Over to you, Dr. Lata. Sorry.
It's okay, sir. I'm very much thankful to Anusha ma'am. She was so wonderful and just conveying all the basic knowledge to the students. It was really she did really a wonderful job. Thank you, ma'am. I'm thankful to all the office bearers, all the senior faculties who are there, and of course, very much thankful to all the students and all the whosoever participated in this program. I think I don't know if we have Nehal madam with us.
I'm there, but it's your turn to do the things. So thank you so much, Lata. Being a chief project coordinator, she is working so hard and fulfilling my president's dream of presidential action plan at a very nicely. Thank you, Sandeep Bhai. Thank you, Rekha, for mentoring such a wonderful. Thank you, Anusha, being there.
Thank you for inviting me. Thank you so much.
Thank you. And thank you all the students. Thank you, Richa, presenting so nicely.
Wonderful.
And thank you, Baldev sir. You are always there for our PG road ahead.
Nehal just announced our West Zone Pedicon and Good Neocon at Narayan Health.
Yes. So we are having West Zone Pedicon with Guj Neocon, combining both the neonatology and the pediatrics on 14, 15, 16 August. So PGs are invited to have their presentation, paper presentation, poster presentation, and even to attend the workshops and conference. Thank you so much. Good night, all.
Thank you, everybody. Good night.
Good night. Thank you. Thank you, sir. Thank you. Good night, Baldev sir.
Good night. Good night, everybody.
Yeah. Anusha madam, good night.
Thanks, sir. Good night. Good night. Good night. Bye.